Good morning to you all. And Manos, thank you again for the invitation. It's a real pleasure to be here. Now, the classic Latarjet. This procedure has been the gold standard for many for a long time, namely the French, but also for myself. It's been like 20 years at the beginning of my residency that I learned it. Also later on during my training in France. Now, although despite the technique is widely known, every surgeon tends to put a special touch to his own technique, to the way he does it. And that's what I'm going to try and share with you, what has made over the years, made this procedure a little bit easier for me. But recently, the discussion has moved another way, whether you should do it open or arthroscopically. And when you look at your patients, like this arthroscopic Latarjet of mine with 7 incisions, one of those incisions about 2 centimeters long, you inevitably think and reconsider all your options. Now, I do believe that the open Latarjet is definitely a fantastic procedure, and let's start with the positioning. Now, this is more or less the way you place your patient on the table, and as you can see, the shoulder blade is not exactly horizontal, so you have to take care of that, because this is kind of the way you look at the shoulder when doing an open approach, which is not exactly the direction you want to give the screws. So you have to move that shoulder blade a little bit, and one trick is to place a small pillow on the back. Now, I've done this sometimes, but that depends also on the patient, on the type of patient you have, because sometimes the patient tilts a little bit. It can become a little bit uncomfortable, namely if you're right-handed and if you're working on the left shoulder. So one other option, which is what I do all the time, is placing the patient at the end of the table. So you just leave the shoulder off the table, stable enough, but with the middle part of the shoulder blade on top of the table to enable pushing it backwards and placing the shoulder blade a little bit more horizontal. I use a neck brace to hold the neck. I don't like using head holders. I think that's a little bit dangerous, because if you move the torso of that patient, you run risks of tractioning any nerves on the spine. And then use a band to fix the head to the table. The incision, about 3-4 centimeters, that's enough. After the years, you realize that it's not exactly the size of the incision that can get you into trouble, but the quality of the retraction down there. In fact, you can even adapt the incision. You can put it a little bit more vertical in order to hide it by the bra strap, in case of a woman, of course. And then move to the approach itself, classical deltopectoral. I like using my finger for a blunt dissection, because you're going in between muscular structures, so it's an anatomical approach. And then you place an Hohmann retractor on the top of the coracoid. Then section the pec minor, section the coracoacromial ligament, leaving a stump for later repair. Then the osteotomy of the coracoid. Many surgeons use a right-angled saw. That's quite popular. I would rather use an osteotome. It's quite fast and simple, as you can see. And you don't really need to enlarge the approach to the medial side of the coracoid, so I believe it's a bit risky, less risky, I would say. And then continue with the preparation. Again, finger blunt dissection. You can use a gauze for that to get the coracoid to yourself out of the approach. Just take care and be cautious when doing this, because you can stretch the muscular cutaneous nerve. Oftentimes you can see it well. It's in the medial part of the muscle belly. And then prepare the bone. So you get rid of those minor chips on the osteotomy edge. That means you're in the best place, that is in the elbow of the coracoid, and then decorticate it with a burr. There are other options. You can use a rongeur, but I like using this. It's quite easy and fast. Then do the drilling. 2 3.2 drill holes in my case. That depends obviously on the kind of screws you choose. About 1 centimeter apart, one from the other, because you have to leave room for the screw head, and just do them a little bit away from the osteotomy side, the osteotomy edge, because you run risks of breaking it if you do that. And then the subscap split. You should, well, first of all, obviously get rid of that fascia, that part of clavipectoral fascia. Move the coracoid to the medial side and inferior side, and then continue with the dissection. Identify the upper and lower board of the subscap, and then open it between the middle and lower thirds in a horizontal fashion on the direction of the fibers. If the scissors is not good enough for that, just take the electrocautery, open the fibers in line with the direction of those fibers, take the scissors until you see the capsule underneath. So this is quite straightforward. It's no real big deal. And once you get that, just place a Galpi retractor to open the capsule. So use your finger to identify properly the glenoid rim and do a vertical capsulotomy. And then moving on, and this is the tricky part where you should be patient and try and get the best exposure possible. Oftentimes that Galpi retractor with a Hohmann retractor will do the job. But in muscular guys, that's often not enough, so you will need a Steinmann pin to place on top of the glenoid to retract the upper fibers of the subscap, a blade glenoid retractor on the medial side, that Hohmann retractor I mentioned in the inferior side of the glenoid neck, and some kind of Fukuda type retractor inside the joint to lever the head and give you more room to work. Now, a quick word on the axillary nerve. That's a structure you wouldn't need to see when doing this procedure, but beware of where it is. And when placing that Hohmann retractor in the inferior part, you run risks of damaging it. So just be cautious, gentle, and do not abduct the shoulder above 45 degrees, because that makes those structures in that location get closer to the joint line. And then decorticate the glenoid neck with exactly the same burr you used for the coracoid preparation. Next step, doing the drilling. There are specific guides in the market you can use for that. I've used them sometimes, but they can get cumbersome, and the retractors can get on the way, so I would rather stick to the freehand technique. So using those two long of the same length drill bits, I use my finger to hold it, or some kind of forceps, and place the two drills. Then take one of them and leave the other one in place. A quick mention as well to the suprascapular nerve. Also be aware of that when doing this drilling. So the best way to avoid this or have less risks of damaging it is try and get those screws and the drilling as parallel as you can to the joint line, and also control the superior tilt. In fact, it's inevitable that there will be some superior tilt of the screws because you're placing the coracoid in the lower side of the glenoid neck, but still don't go too superior, because in fact that's where the suprascapular nerve is. And then continue with the fixation with the screws. I like using two bicortical 4.5 non-cannulated malleable screws. That's the kind of screws I've used it for ever, I would say. And fix the first screw with the drill in place, the first drill in place. Then take that drill and go for the second one. That will help you estimate the proper rotation and avoid moving of the coracoid. And now a few surprises that can arise. This was one case I did some years ago in which I was surprised to see a deformed and very thin coracoid in that patient. So there was no way I could drill two holes to place a screw in that patient. When I reviewed the data on that patient later on after the surgery, I realized there was a former fracture of that coracoid that I left past, that I missed, and probably following some of the dislocations, or maybe that AC joint dislocation, I wouldn't know. So I had to find a plan B during surgery, and that was fixing the coracoid tip with an interference screw, as you can see here. So you have to be prepared for this and have all the stuff you may need available in the OR. Another surprise that can arise, not so rare as the previous one, is having a fracture of the coracoid. Well, usually it's longitudinally, but it's easy to try and avoid it. So do not over-tighten the screws when fixing the coracoid to the glenoid neck, and do not drill close to the osteotomy end of the coracoid. That will ensure that the risks of having that surprise are lower. Solution for that, using a wire or suture, seclage, and maybe a washer. And then the capsule repair. That's something that's sometimes underestimated. I did underestimate it a long time ago, but once you have evidences that some Latarjets fail due to redundancy of the capsule, you realize this is really an important issue. And then closure, again, underestimated oftentimes. Just always do subcutaneous stitches to avoid skin tension. That's one of the reasons why you have keloids in these regions. And then just stitch or do an intradermal suture of the skin, which you should take out at day 5. As final messages, open does not necessarily mean that it's easy. Just make sure you have the right tools. Oftentimes, if you change from OR to the other, sometimes I'm invited to other ORs, colleagues that want me to do the surgery, and you cannot really control what's happening there. Doing a large incision does not enhance the view. Retractors do, be aware of that. And we're talking about an anatomical approach in between muscular structures, so you don't cut that much. So I do believe that finger blunt dissection is a fast and safe and effective way of doing this. And to avoid risks of nerve lesions, always stay lateral to the conjoint tendon. That's probably the best way to avoid iatrogenic lesions. Thank you.